is a NATH presentation regarding medically unexplained symptoms and trauma-informed mental health support. I'll start by introducing myself, then I'll introduce our lovely speaker for today as well, and we'll briefly go over some housekeeping as well, if that's okay. So I'm Manali. I'm a GP by background. I work in Hyson Green in the forest practice, and I'm also a educator or GP associate for the Nottinghamshire Alliance Training Hub, who have brought you today's session. Our lovely speaker today is Lucy Rickwalska-Brown, who is the head of service for BU NOTS, who has very, very kindly given up her lunchtime on her busy day to bring you this presentation. We've got quite a big group of us today, which is excellent. We've got about 20 attendees so far. From what I can tell of the attendee list, we've got a good mixture of attendees. We've got social prescribers, health and wellbeing coaches, some doctors, some nurses, some admin, receptionists, practice managers as well, a few pharmacists, I believe, as well. So we've got a good mixture of the multidisciplinary team. We do like our sessions to be as interactive as possible, so do either unmute, speak up if you want to, pop your questions in the chat. We'll come to questions formally at the end of the session, but if you do have anything bursting, then by all means do ask as we go along if you want to. We do, as we said, we do like our sessions to be interactive. So if you can have cameras on, if possible, we do like to encourage an element of networking in our sessions as well. So it'll be nice to see faces if possible. Don't worry if you're eating. It is lunchtime. So if you're eating and drinking, by all means do. Don't feel you're being rude or anything like that. And just to let you know also that this session is being recorded, and that's largely due to high demand, actually. So we're hoping to record it so we can reach a wider audience in the future and share it via our channels. Just bear that in mind. But of course, do ask any questions, do share experiences. And if you do want to share any cases, make sure you just keep them as confidential. Don't mention any names at all. And without further ado, I'll hand over to Lucy. Thanks, everyone.
Thank you so much. Thanks for having me, everybody. So really, without further ado, I'm going to go to the first slide and just tell you a bit about what we'll be talking about today. So we'll be talking about kind of terminology, the way that we describe this very unique, very individual presentation, symptoms and presenting issues, the fact or fiction slide. We've also got a video. I'm going to talk to you about a case study, a bit about the cycle of effect. I was raised in the 70s and 80s, so you've got a Columbo slide to share with me, and some key considerations as well. So, okay, so if we look at terminology, so MUPS, we hear that term quite a lot, that abbreviation MUPS, medically unexplained physical symptoms. In different parts of the world, we might hear somatic symptom disorder, or just plain old medically unexplained symptoms. So what we do know, and of course, a lot of this, just to give you a bit of background, I was fortunate enough to work with Damien Wood, Dr. Damien Wood at the Nottingham Children's Hospital. And I was given my own clinic to work with these young people. So again, this was a very special cohort of patients that really needed that person-centered, therapeutic and social approach. So much of my learning was from that period of time. So it will give you a little bit of insight. So what we do know is that symptoms can last for more than a few weeks. And often what happens is doctors just can't find a reason why these symptoms seem to be there. You know, what we do know is that some patients, some young people can find themselves in hospital for a long period of time, having all different kinds of tests, but yet nothing can be found. But this doesn't mean that the symptoms are faked or that they're all in the head. They're very real to the young people and can affect their ability just to function properly, which, as we know, can lead to social isolation, low mood, depression. Not understanding the cause can make the experience even more distressing and difficult to cope with. And what we find is it's important to validate the individual's experience and help them to understand what that possible cause could be, and then support them in managing or overcoming, that's the goal, their difficulties. So some common presentations are pains in the muscles or joints, backache, headaches, tiredness, that real fatigue that is really debilitating, feeling faint all of a sudden, chest pains, heart palpitations, and a really frequent presentation is stomach difficulties. So pains in the stomach, bloating, yeah, and difficulties going to the toilet as well, actually, is very frequent. However, in my experience, the less common symptoms include partial paralysis of one or more limbs, non-epileptic seizures, those seizures that have no clinical basis, some selective mutism, visual disturbances or impairment, and audio disturbances or impairment. So again, I'll talk to you a bit more about this later on. So, fact or fiction? I think I've heard this so often, particularly in schools and even in families. You know, it's a phase they're going through. It's all for attention. It's all in their mind. Tell you what, if we leave it, it's all about growing pains and growing up. It'll sort itself out. But what we often see is, do you know what? It doesn't. And it's not chronic fatigue syndrome. This is not ME. This is a different presentation. I might have jumped one there, bear with me. Right, okay. Got a bit of a video to show you. So if you can't hear this, can somebody wave at me and I'll try and put it right.
We all have aches, pains, and odd sensations in our bodies now and again. Most of the time, we know that these are part of our everyday life, that they'll go away on their own, and we can ignore them. If they become more painful or uncomfortable or unusual, we know they could be signs of an illness, and we call them symptoms. Sometimes these symptoms just cannot be explained, and about 1 in 4 people who see their primary care physician have these types of collections of symptoms. In the clinic I did just yesterday, over half of the patients had this. They're called medically unexplained symptoms. Medically unexplained symptoms are really frustrating because the tests, such as an examination or blood tests and scans, are all normal, but you still have your symptoms. And an important part of getting better is understanding what the problem is. But in this scenario, neither you nor your doctor know exactly what's going on. The commonest types of medically unexplained symptoms can be anything from pain in the muscles or joints, back pain, headaches, feeling tired, feeling faint, having chest pain, having heart palpitations, having stomach problems. It's a very long list. Medically unexplained symptoms is not like other diseases. There are often loads of causes, and these often stretch back to childhood. I'm thinking of things like being ill as a kid, or having ill parents during childhood, or just having a tough childhood in terms of adversity or abuse, or having certain personality traits. We can't do much about any of these things. We can't do much about our genes or our parents or our health as kids. But this is where environment, upbringing, social stability, parental bonds are paramount, and it clearly goes far beyond spraining a muscle or catching an infection at one point in time. Often with people that have medically unexplained symptoms, physical and psychosocial stresses have occurred prior to the onset of these symptoms. Once a patient shows these medically unexplained symptoms, what I mean by that, again, these physical symptoms associated with mental health issues that just don't fully add up. There are maintaining factors which keep these symptoms going. What I'm thinking about are things like physiological factors. This is when some of our key bodily functions and pathways go awry. Things like dysregulation of our autonomic system, hormonal and immune dysfunction, and metabolic abnormalities. These are real changes to how your body functions. But again, this is a bit of a chicken and egg.
Sorry, I'm just letting somebody in.
Situation. We don't know if these changes come first and then you have symptoms, or if you have symptoms secondary to something that causes these changes. Other types of findings are social findings, like a loss of role and medical uncertainty, cognitive issues like symptom focusing and a complete intolerance of uncertainty help make these symptoms much worse, or behavioral factors that prolong these symptoms. This is things like avoidance behavior, not seeking help, all or nothing behaviors, and having very poor sleep hygiene. So while we can't modify the causes of medically unexplained symptoms, those things like your genes, your childhood or your parents or your relationships with them, we can modify these maintaining factors, especially the cognitive and the behavioral. So why does it all happen? When something in your body doesn't feel right, there's usually a bodily or physical cause. Stomach problems may be due to an infection, or palpitations may be due to a heart problem. If there's no physical cause, we can often understand and explain these symptoms when we look at how our thoughts, how our feelings and stresses affect our bodies. Medically unexplained symptoms aren't all in the mind, but neither are they all in the body. To understand them, we have to think about how the mind and how the body work together. We often think of our minds and our bodies as two separate things. They're not. They work together and they affect each other intimately. Research shows that there is a two-way communication between our brains and our bodies. This happens because signals travel down the nerves from the brain to the body and back again from the body to the brain. They communicate. Natural chemicals like hormones circulate in the bloodstream. Some are produced by the brain and affect the other parts of the body, and some are made in the body and they affect the brain and the way we feel. Every day, thoughts, feelings and stresses play a part in making changes in our bodies. So for example, when we feel embarrassed, we blush. If we feel worried or frightened, it can cause an uncomfortable feeling and butterflies in our stomach. When we get upset, we can feel our throat tightening and causing a lump there. We also know that the way we think and feel can make us physically ill. So for example, feeling low or stressed makes any pain we have feel so much worse. That's why managing pain in people that are low and depressed is very, very hard. Long-term stress can make us more likely to have high blood pressure or a heart attack. A disease in the body can affect the way we think and feel. It's common for people to have a physical illness and to have physical symptoms that are not fully explained by that illness. This can happen for a number of reasons. Stress or a physical illness can cause emotional stress, which then creates physical symptoms of its own. Imagine someone with an illness such as asthma or emphysema who finds it hard to breathe at times. This can be frightening, which triggers the stress reaction. This makes them breathe faster and their chest feels tight. But this is a vicious cycle, and it's created whereby breathlessness and stress each make each other worse. The breathlessness is then out of proportion to the illness that triggered it in the first place. Let's think about pain. A painful physical illness can make us feel depressed. This lowers our pain threshold and makes the experience of pain worse, and another vicious cycle ensues. Or even worries about our health. If we know that we have a physical illness, we may be more alert for bodily symptoms that could indicate that our health is getting worse. We might find that sensations that we would otherwise ignore, such as aches or pains, become symptoms that we cannot stop worrying about. We can give a name or a diagnosis for symptoms when they occur together in a particular pattern in people, or when they share a similar cause. Sometimes groups of symptoms commonly occur together to create a pattern of medically unexplained symptoms without any physical cause. So I'm thinking of things like irritable bowel syndrome, which causes troubling abdominal symptoms, or fibromyalgia. This causes widespread bodily pain and tenderness. First things first, this is tricky stuff. Anything that is rooted in a complex biopsychosocial history won't be solved in a 10-minute consultation. If you have a range of physical symptoms that don't make immediate sense, then you should have a detailed history asking about symptoms, childhood, and family history. A physical exam is useful too, to exclude other physical conditions and basic observations, and a blood test would be pretty standard practice here. This helps to exclude common conditions that can sometimes masquerade with non-specific symptoms, things like diabetes, celiac disease, thyroid problems, or weird inflammatory conditions. How can you help yourself if you have these medically unexplained symptoms? Tackle your other stresses. Are there any other stressful things going on in your life that may be affecting how you feel? Almost 9 times out of 10, when I ask patients about stress in their life, they can directly link their symptoms to something that has happened in their past. Even more so, with irritable bowel syndrome, 50% of people credit the onset of their symptoms of irritable bowel syndrome to one acute traumatic experience previously in their life. These things matter. Can you talk to someone about these issues? Can you get any help or advice to manage the situation? By reducing stress, you might find that your symptoms get better and you feel better too. Get healthy too. If you feel generally healthier, you may find that your symptoms bother you less. Try to eat healthily and cut down on smoking and alcohol. Try to get enough sleep and have a regular sleep routine that you stick to. And do exercise regularly. This helps to strengthen muscles and makes us more fit. Don't overdo it, of course. This can make you feel more tired and unwell. Build up. Gradually take time to relax. This helps manage these symptoms. People who notice these symptoms often have very poor maladaptive mechanisms to manage stress and manage their difficult situations or feelings. This might mean making time for you to do something that you enjoy or that distracts you from your problems. Learn some relaxation techniques. This is really important. There are many self-help books and websites that help with this. Don't keep looking for reassurance and information about your symptoms. If you find that you spend a lot of time worrying about your symptoms, remember that repeatedly looking for reassurance or information is usually unhelpful. Reassurance often doesn't last long and the worry comes back very quickly. Similarly, spending too much time looking for information about your symptoms, such as on TV or in books or on the internet, can make you more convinced that there must be a physical illness to account for your symptoms. Again, I find this time and time again in my patients that have medically unexplained symptoms. They have always trawl the internet and always think they have something horrible. The main options here are drugs and talking therapies. Antidepressant drugs, we use these to treat a range of problems, not just low mood, and it can really help with medically unexplained symptoms in a number of ways. Sometimes the symptoms are part of anxiety or depression, in which case the symptoms will improve if the depression or anxiety is treated. A vicious circle could be set up between symptoms such as pain and depression. Antidepressants can be helpful to break this vicious circle, and both the depression and the symptoms can and do improve. Some antidepressants can act as painkillers, and they may even be prescribed for things like chronic pain, even when someone is not depressed at all. And some antidepressants can even help to treat a range of medically unexplained symptoms, even when someone is not depressed. We're not sure how they do this, but the evidence does show that they do work. There are different types of talking therapies that can help. The choice of therapy depends upon the sort of problem and the type of therapy that seems to agree with you. The mainstay with all of these therapies is that they try to help with recognizing what makes your symptoms worse. They help you manage the stresses that might contribute and exacerbate these symptoms, and they help to develop ways of coping with and living with these symptoms. The mainstays of these types of therapy are cognitive behavioral therapy. This helps identify those unhelpful thoughts about yourself and your health, which can make your symptoms worse. Then there's psychodynamic therapy. This can be helpful when you've had these early life experiences that often play an important role in medically unexplained symptoms. And finally, problem-solving therapy or solution-focused therapy. This helps to identify and tackle specific problems in your life that seems to be making things worse. Most people who see a doctor like me with these types of bodily symptoms that aren't due to a physical illness are helped by talking about how their symptoms are caused and what they can do to help themselves. Some people have symptoms for a long time, especially if there's a lot of long-term stress, which is pretty much everybody, and if they have a lot of medical appointments and investigations. It's not always easy to understand that there may not be a single physical unifying cause for the symptoms that you experience, especially if doctors have spent a lot of time looking for physical illness. Even if you've had symptoms for a long time, there is much that can be done to help you live a better life and to avoid the unnecessary agony and treatments and investigations investigations that come when your mind fixates on these medically unexplained symptoms. Thanks for watching. Till next time, stay healthy.
There we go. Okay, we're going to look at a case study now. So I've anonymized this case study, but this is a young person I have worked with. Okay, so James came along to the clinic and he lives at home with mom and dad and his older brother, David. And David is studying biochemistry in Derby. So James has started studying for his A-levels, and his brother David is a high-achieving young person, acquiring 9s in his GCSEs and A's in his A-level. The brothers are really close. They hang out together quite a bit. They do gaming together. They go out, go to the cinema, but they're highly competitive too. In January this year, James became really unwell and eventually lost mobility. So basically lost use of his legs, which led to him becoming a wheelchair user. So after, so relying on the support of dad to get up and down the stairs, actually having to set up a bed downstairs. So actually the family have had to make some massive adjustments in order to support James. And of course, I worked really closely with the GP who arranged a referral to a consultant. And James has now spent 3 months in and out of hospital. So admitted and discharged, can't find anything. Let's try something else. Another admission, another discharge, can't find anything else. There's no medical reason. So I'm just wondering if anybody's got any ideas based on that very short piece of information. So I can open that up right now if that's helpful.
Any thoughts, everyone? You can pop it in the chat if you prefer not to speak up, but do unmute and speak up if you wish to.
That was quite good. I gave you a few clues there. So hopefully.
I was wondering whether it's anything related to family pressures, underlying stress. We've got a few answers in the chat that I'll read out. Someone else says underlying stress from high achievement, accumulated comparisons, stress and striving, perfectionism, someone's mentioned as well. Any other thoughts, everyone? High level of stress related to exams and competitiveness with the brother, relying on dad more and the social or relationship with the family. The transition, the change from GCSEs where they're a little bit more supported to A-levels, where there's a little bit more autonomous working. Trying to be perfect, overdoing it, fatigue in his body. Absolutely. Lots of great ideas, everyone. You're
all right, actually. So I'm going to... So which is great. It's kind of a mix of all of those things. But so what happened was this admission went on and on for a further few months, actually. And I started working with James, and I ended up including the family in our consultations. And it was almost like a bit of a family therapy session that we started. And we went away, and I kind of sat with James. And I said, and actually I had noticed there was an awful lot of inconsistency around the presentation. So I was in this position where I was able to see the way in which James mobilised, kind of transferred from wheelchair to chair, from wheelchair to standing, and just nothing kind of added up really. And then on one particular, I was invited to a trip which involved mobilising onto a narrowboat. So this wheelchair was taken onto the narrowboat, and James came out of the wheelchair and started using knees and things like that to get around. And well, that's taken an awful lot of strength to get around on your knees, get around this narrowboat. So it's really interesting. But, I certainly didn't judge, and that's the worst thing I could have done. And I just really wanted to find out what was going on, because what I was seeing was a presentation really kind of like based within stress and anxiety. Something didn't feel right for James, and I really wanted to help him. Finally, we did sit down, and I think there was one day, and it was just, I think we just got the timing right. We were sitting in a room, in the consultation room, and I just said, James, what's going on? Something doesn't feel right for me, and I'm guessing it doesn't feel right for you. Can you tell me about it? And actually what it was, James really, really loved his family, incredibly close. And incredibly close to David, loved David to bits. It's one of those rare sibling relationships that we all hope will happen in our own households, but never does. I mean, they were real rare, rare brothers. So I think what had happened was James, basically, I know what happened. James had watched David achieving more and more and more and more, and felt absolutely almost kind of like frozen. How can I compete with that? I see all this positive feedback and validation that my brother's getting. There's no way I can do as well as that. So what we did, we agreed and we talked about it. And of course, it all made absolute sense. And, and I said, we were able to talk about, that kind of, that attention that we get when we need support, which is a very human condition, very normal, certainly not going to judge it because it is part of being a human being. But that had almost kind of like taken some of that attention from David and placed that attention onto James, which is what was needed. That's what James needed. Eventually, we decided on putting together yet another family therapy session. And I literally sat at James's side whilst we unpicked this together and explained what had happened. The family were wonderful. Stepped straight in and were very supportive. The sibling was there as well. So David was there. I mean, there was quite a few tears, but very much in a healing way. It was almost like this weight had been lifted from the family. It's like, finally, we know that James is all right. There's nothing lurking, nothing serious that we need to be exploring. And eventually, the lovely news is that James walked out of the hospital, and actually has gone on to do amazing things in his life. And is a real role model for others. So, again, I think to have somebody around to take the time to kind of unpick what's happening is so important. And we do know kind of like GPs are incredibly in demand and restricted time-wise, but perhaps that's something that perhaps a youth worker, a therapist, or somebody else could step in and support with. Maybe it's just about making those links. Talking to a social prescriber, we have more of those now. So yeah, it's about finding that very special somebody that will take that time and work with one of these young people that can just make that call and just say, so what is actually going on? And it's fine, you're not going to be judged. No one's going to tell you off, and no one's going to think any less of you. And in fact, in this case, as I say, James has gone on to do the most incredible things. Yeah, he's incredible. Really great young person. So let's have a little look at the cycle of effect. I'm just going to have a little move around because this is quite okay. So the desired outcome relies on identifying the cycle of effect, which is unique to each young person. And it's about kind of like starting anywhere you like within this. Sometimes you can start at number 3 and work your way back to number 1, and that's fine. So consider working from the functional impact. So what's actually happened. So we've got 1 down here. So the physical impact of what the presentation is, the emotional impact, and the social. So exploring that with the young person. So what's changed since this happened for you? What's different in your life? what's different with your body, what's different with the way you feel about yourself and the world around you, and what's different about what you do now. So that gives you the starting point, because what you're actually doing there is highlighting the impact that this presentation is having on their lives so that they can share that with you. So we're going to be a bit of a detective together, so super detectives, and actually start tracing our way back to something that may have happened. It could be an acute situation, it could have been a long-standing thing, but something has happened for this to occur, and it's about working with the young person to find out what that could be. Although managing symptoms is a priority, as I say, dignity, validation, that no judgment here, we just want to make sure that you feel respected and heard, should always be a consideration. And again, saying, paying that attention to both the physical and the psychological response is really important. So yeah, so starting from the bottom, working your way back. So here's Columbo again, dynamic detective. Don't treat the symptoms alone, collaborate or work with the young person to work towards that goal of understanding how and when all of this began. It could be that you do a timeline, and that's a really simple exercise that, we could get a piece of A4 paper. Here's when you were born, and this is today. Let's have a look at the events that have happened between then and now, and try and work out together what could be going on here. Exploring their world, being creative, maybe doing a mind map, putting them at the center of the mind map and kind of working around that to find out what their world looks like. Have there been any, and a real common one at the moment presentation wise is a lot of peer conflict. I don't know if anybody else has experienced that, but an awful lot of peer conflict, that it kind of like really struggling to communicate needs with friends, communicate boundaries. And and we're still talking about COVID because we have to. That was such an important chunk of time in these young people's lives where they weren't given the opportunity to develop emotionally, socially. So actually, social cues and things like that are lost, and we've seen an increase in sexting and things like that, because actually the things that were put in place in 2019 just were put on hold. We were all firefighting for such a long time. So again, explore their world, be creative, get some colours out and shapes, and maybe make a poster or a timeline together. Keep a symptom diary. So where was I when this first happened? Who was I with? Can I remember who I was? Was I on holiday? Was it around the time of my exams, which is another time which is really prevalent? So what happened, almost like going back in time. I often use the Back to the Future car as a bit of a metaphor, and we dial in the dates. Imagine if we dialed in the dates into the Back to the Future car and went back to what was going on in 2021. What can you see? What can you remember about that time? So how long has it been happening? So that's a great indicator, because if it's been happening a year, we know it started last year. So again, we're straight in there. And when was the first time you remember it happening? So again, going back to that, where were you? Who were you with? And almost, just saying together, let's collaborate on this. You're the expert of your life, I'm not. But I tell you what we could do together is, form this detective agency and find out what was going on. Key considerations. Labeling is really difficult. So I think, so often these young people hear, oh, it's all for attention. They're attention seekers. Yeah, they are, but for a very good reason. And it's our job to find out what that is. Promoting autonomy, offering choice and collaboration, and just finding out, does that feel comfortable with you? I'm putting this down, but actually, does it feel all right with you if we try this? And kind of like very small steps and goal focused interventions. Talking about recovery, So in the future, when you've managed this and things are looking a lot brighter, you know, what will be different? You know, kind of putting those goals in place. And boom and bust, so kind of like not going kind of like straight for it, kind of bull in a china shop type, all or nothing kind of approach, just saying, right, let's just take these small steps, and then almost saying, give yourself a reward, maybe a self-care activity. You know, I often use, if they've got dogs and things at home, I often say things like, use the dog walk or go for a walk around the block, and use a playlist. So I almost say, right, make a walking playlist, and that might be up to 20 songs, and we increase by one song at a time, if that makes sense. So once you've finished listening to song 3, it's time to go home. And then tomorrow we'll go to 4, and then you'll go home, and take the dog with you so your dog can listen to the music as well. Annoy everybody walking around you while you're listening to it. And yeah, I mean, it's just a really good tool. Set the goals together and review them together. How did this feel? Was it too fast? Was it too slow? And I think, you know, another thing that this is really useful for all of these things here is in supporting young people to get back into school, you know, giving them the tools and saying, right, here's your timetable. How much do you want to increase this by, your attendance by? You know, okay, so at the very least, you know, a baseline might be that you're going to start going in at lunchtime to see your friends. And that might be no lessons to start off with, and then start building into lessons and saying, right, okay, so if you're going in on a Wednesday to see your friends, I can see it's English after lunch. How about that as a starting point? And then saying to them, right, what next? Not asking them, you know, if they're, you know, it's like, so what do you want to happen next? Which classes do you want to get into? So again, setting goals together, reviewing them, and moving forward. So suggested support is that we don't minimize or dismiss. We always maintain recovery focused language. When this is better, in the future when, and all that kind of language. Validate all progress, but then move quickly. Don't stay with the progress that was made for too long. Validate it, celebrate it, and then go to the next step. Encourage planning and goal setting, as visual and as creative as they want it to be, and as bright as they want it to be. Suggest lots of distraction, positive feedback about achievements, even appearance. I can see you really smiling today, and it's so good to see. You know, just saying that means such a lot. Using their personality traits as well, because in doing that, what we can do is identify their resilience, their existing resilience. So, you know, you're really kind, and you've talked to me about a friend that you helped out last week, and I really remember that. And I'm just wondering if there's a friend that could help you in the same way, you know, kind of using that kind of language as a tool. And again, using the strengths-based approach to inform their recovery. So always highlighting progress, protective factors, and examples of resilience and strength. Again, what we know is what we heard in the video is that the mind and body connection is a really influential relationship. They work together such a lot. And the mind and body are designed to be allies, and they're meant to work together to maintain our physical and our mental health. But sometimes they do work against each other, and that's when this dysfunction appears. The mind and body collaborative approaches focus on strengthening the connection between an individual's mind and body to maintain or improve their health and overall well-being. You know, so sometimes, for instance, you know, if I've worked with a young person who might be having treatment that they're really dreading, or I actually say, right, okay, if this was a visual, could this be an army? And would this be, what would your army look like? So say, for instance, young people who may be on infusions for whatever their condition may be, you know, think of that army traipsing through your body and getting rid of all the negativity and all the things that aren't helpful. So, you know, looking at that mind and body collaboration, that approach that says, let's get them working together. And if you can use metaphors and visualization, even guided imagery, then, you know, really useful things in your toolbox. So routine and structure is great, and it's a really good excuse to go out and buy some fantastic stationery. Now, if you're anything like me, I do not need any encouragement to buy fantastic stationery and colourful pens. In fact, I recently purchased Popper Point pens for my whole team because we used to love them when we were children, and they're just really great. So encourage these young people to go out and buy themselves these journals. There's some beautiful ones out there, and maybe they can make their own. There are even those you know, wreck-it journals. I don't know if you've seen them, where you destroy them, stamp on them, pour coffee on them and all sorts. But what I always say is, whatever's going on in here is important. You are precious, and it's really important that we give you the respect, and you give you the respect you deserve. So actually, for me, the companion journals that I recommend are treated with respect, because that's what they deserve. So, you know, making lists, even at the start of the day. Today, my goals are to get up, to make myself breakfast, to form some kind of routine. And even if the routine is really bare bones to start off with, and it's getting up, brushing my teeth, having a shower, going downstairs, making breakfast, taking the dog for a walk, coming back, rewarding myself by watching Netflix for an hour, doing some revision, whatever that is. But structure, you know, encourages kind of like that feeling of safety. I know where I'm at today. I know what I need to do, and I'm just going to move through my list as I go through the day. So in summary, medically unexplained physical symptoms, it's a term that's given when doctors can't find a physical or biological reason for a patient's symptoms. Symptoms can typically be fatigue, pain, sometimes more unusual presentations, such as partial paralysis or seizures. Responses which suggest that individuals are putting symptoms on or faking it aren't helpful, and they do form a barrier to recovery. The mind can feel so overwhelmed that the body responds. It's as simple as that, really. And we need to reset the mind and body so that they start working together. And a strengths-based approach informs the best possible outcomes. And most importantly, you know, recovery is possible. They can win. And that's it for the first one. So I hope that was useful. So if you can just bear with me while I bring up the next presentation, I'll let you all have a breather.
Emma's put a really interesting point in the chat about her dislike for the term attention seeking, which of course very much agree with, and the consideration that we should perhaps rebrand it as connection seeking rather than attention seeking. And I would agree with that, Emma, because these people are not seeking attention necessarily. What they're looking for is actually often an explanation as to why they're feeling the way they do, and often they're feeling as helpless as the people around them. And Imogen says, absolutely, help seeking, absolutely. They're not after attention, they're after support, they're after help.
Absolutely. Any more?
Susie's popped a question in the chat. So Susie's asking, how do you balance recognition that it is possibly a psychological response with the shame that some people feel around this?
I think when I work with young people, I normalize it. And, you know, sometimes we all need something. And again, you know, I'm very explicit in the way that I'm transparent in the way that I work, and just say, you know, there's no shame in this, because the mind and body it's just stopped connecting. And even with the shame and the oh gosh, how can I face anybody again, that kind of feeling, that was a really important part of the work I did with James. Huge part of the work, that prep session before we met with the family. It was like, you know, it's for me, it's no biggie, James. At the end of the day, what's happened is, you know, you're feeling like this and your body has responded like this. It's as simple as that really. What we need to do is give your body the messages it needs, which is you can let this go because you're fantastic in your own right. You're not your brother, but I'll tell you what you are, you're fantastic in your own right. And this is why I know that, and giving them something with substance in return.
That's really interesting. That's really useful as well, Lucy. Thank you.
Oh, you're welcome. So I am just going to see if I can share this. Any more whilst I'm working out the technical side of things?
Yeah, Lucy, I was just, I'm a psychiatric nurse working with people with
Hi.
personality disorders. And yeah, we see this so much. And yeah, the attachment, especially attachment issues, because yeah, I went on maternity leave and one of my patients ended up in a wheelchair when I went on maternity leave. And she didn't come out of the wheelchair until I came back.
I can believe it. I
Yeah,
can believe it. It's
I
that
was
powerful.
so shocked when I came back and saw her in the wheelchair. It was very powerful, and yeah, it seemed to be around seeking care and the attachment she had to me. Yeah, but I was very shocked. I wasn't expecting that when I came back from maternity leave.
But how powerful it is when we unpick that with somebody and say, it's all right that you've got that attachment to Anne-Marie. It's understandable. You know, just saying, look how much you've worked together. Look how valuable that relationship is. And actually what we do know is Anne-Marie's coming back. So what we need to do is support you during that time. So just somebody that could go in and do that.
She wouldn't accept anyone else. She
really
refused to see anyone until I came back. So she had someone to check in with and crisis team and things, but yeah, she wouldn't accept another worker.
Unbelievable, honestly. But again, you know, I've seen it, and even kind of I remember a young man coming into clinic and clearly he was experiencing paralysis. And it was all around self-esteem and identity, and his arm just wasn't working, you know. And by the time we finished working together, off he went, and we even organised a residential for this cohort of young people, and that was transformative. The words I can't even tell you. To see the young people that had come into the clinic presenting in this way, and then to be socializing and sharing their experiences together and learning about, you know, mindfulness and meditation and things that they could take with them, you know, into their next stages of life. Yeah, it was superb.
Thank you.
Okay, so
Thanks, Lucy. Shall we kick off with the second half?
let's do it. Okay, so I am a trauma-informed practitioner, and I put this together just to support my colleagues, and like a bite-sized model that we deliver at BU NOTS. So hopefully you'll find it useful. So what we're going to do, we're going to look at the adolescent brain. We're going to look at the impact of childhood trauma, types of trauma we might experience, and the impact of that trauma on the growing adolescent brain. We're going to look at developmental trauma, disassociation, therapeutic goals, and interventions. So this is a difference between trauma and PTSD. So trauma is time-based, while PTSD is longer term. It's a longer term condition and actually can go on for the rest of somebody's life and be very impactful. And it's where one continues to have flashbacks and re-experiencing those memories of whatever the traumatic event may be. Trauma is slightly more subtle, believe it or not, in a lot of cases, but the presentations may not be, which is what I want to talk about. So we've got some really cool videos to show you here, so I'll rest my voice.
Between childhood and adulthood, our hormones kickstart a phase of significant change. And while the physical changes of adolescence may be obvious, less visible are changes that these hormones trigger in our brains. which might just be responsible for turning our teenage years into a bit of a roller coaster. Throughout our lives, our brains undergo a process called neural pruning. The synapses through which our neurons communicate are either lost or strengthened, depending on how much we use them. Well-used synapses grow strong, while the weaker ones fade away. It's this process that makes us capable of faster, clearer, and more complex thought as we grow up. But crucially, pruning happens at different rates in different areas of the brain. By the time we're adolescents, the neural networks that communicate emotions and reward are well developed, while others, which may help us to plan, prioritise, think logically, and moderate our social behaviour, are yet to mature. So, a potential mismatch between our emotion and our judgment arises just as our emotional and social worlds are becoming more complex, making an increase in social anxiety quite normal at this time. Researchers at the University of Oxford want to know how this might affect our behaviour as we progress through our teenage years. In a recent study, they focused on the social worries many of us feel as adolescents. When presented with photographs of ambiguous social scenes and asked to imagine themselves in the picture, anxious younger teens were more likely than others to perceive negativity. But while these heightened emotions and the struggle to control them can make adolescence a difficult time for some, it's also a golden time for learning and growth. The adolescent brain is particularly agile and flexible, and as such, it's especially open to new opportunities, new technologies, and new experiences. But while teenage years may feel pretty weird, they're also pretty wonderful. To explore how your brain develops, visit www.oxfordsparks.ox.ac.uk and tell us what you think on our Facebook and Twitter.
So we'll go on to the next slide. It lets me, hang on. Okay, so different types of trauma. Okay, so we've got the acute trauma. Again, I talked about PTSD, that single event that leaves the individual feeling powerless, and that fear, that fight or flight. And that can include severe illness or injury. Think of an RTA, a violent assault. It could also include the loss of a job, a home, a relationship. And actually, when we think of the displacement that, we work with young people from the Ukraine, that's an acute trauma, and actually it then goes in to other types of trauma, but that, witnessing what they've witnessed again is acute. And then we've got chronic, and that results from exposure to varied and multiple traumatic experiences. So we see that so much with domestic violence and sexual abuse, and also neglect. So that chronic, that trauma experience actually can follow us through life, and definitely deserves treatment and time invested. And then we've got the complex, which is multiple traumatic or prolonged events, again, such as long-term abuse, so observing it and experiencing it, domestic violence, war, and civil unrest. So that takes all of that acute and chronic, mixes it up and says, right, this is now complex. So impact of childhood trauma on the brain. So cognition, there's an impaired readiness to learn. There's almost like that frozen state that I see a lot of, kind of difficulty problem solving, because you know what, I just feel overwhelmed all the time. That's my foundation. Language delays, concentration difficulties, and even academic achievement can change completely after traumatic events compared to what it was beforehand. Physical health, so we see sleep disorders, non-compliance in going to bed and preferring to be up gaming till 4 a.m. and things like that. Poor immune system functioning, cardiovascular disease, and a shorter lifespan. Emotionally, there can be a difficulty regulating your emotions, recognizing what the emotions are and where they've actually come from. So that's where that emotional literacy really is important. Limited coping skills, so decreased resilience, increased sensitivity to stress, shame, guilt, worry, feelings of helplessness. Relationships, we see attachment problems and disorders, difficulty forming relationships, communicating needs. Problems in romantic relationships, really struggling to maintain those. And with mental health, we see really the whole spectrum, if I'm being honest. So depression, anxiety, low self-image, the PTSD, suicidality, self-harming and risk-taking behaviours, poor self-regulation for behaviour, social withdrawal, just that inability to think, outside of the house, even never mind outside the box, almost, I'm not going to do that. It's that clear, no, I'm not willing to engage. Poor impulse control, drug and alcohol misuse, sexually acting out, that kind of thing. And brain development. So we know that brains are smaller. We can see evidence of that. Less efficient processing, impairment to stress response, again, that inability to regulate and almost think logically. It's that kind of like, boom, I'm in trauma and I can't get out of it. And changes in gene expression. Another video for you here. It's a short one.
Brain development is much more than a story about biology. From the earliest years, relationships with others play a key role in shaping how our brain grows and develops. Early relationships, where there is abuse and neglect, have a long-term impact on children. A brain that has adapted to survive in a threatening or unpredictable world may not work so well in an ordinary environment. This can create what is called latent vulnerability, where early abusive or neglectful experiences with carers put children at greater risk of experiencing mental health problems in the future. For these children, compared to their peers, common experiences like moving to a new school can feel more daunting and stressful. New faces can appear threatening, while positive social cues can be missed. It can be harder to negotiate new social situations and learn to trust new people. Even fun experiences like joining a new sports team can be challenging. Too much focus on potential threat cues can mean missing out on positive social cues, such as a playful nudge. Or it causes an overreaction, which leads to an increased risk of conflict and sometimes violence. These reactions can increase the likelihood of generating new stressful events. It's harder to deal with everyday challenges when you feel unconfident and anxious inside, and harder to build and maintain relationships. Over time, this can mean a child loses friends and the support of adults, and so misses out on opportunities to grow and develop. This social thinning can increase the risk of mental health problems in the future. Neuroscience research is beginning to shed new light on how vulnerability unfolds over a child's life. All children need care and stimulation from adults who value them and who show them attention and love. These experiences shape a child's brain development. When children face traumatic experiences like abuse and neglect, their brain adapts to help them cope. We know of changes in 3 different brain systems: the reward, memory, and threat systems. Experiences of domestic violence or physical abuse can lead to hypervigilance, where the brain reacts more to threat. This might help a child stay safe in an early adverse environment, but it can cause problems in more ordinary environments. Hypervigilance can best be understood as a pattern of adaptation rather than a sign of damage. Abuse and neglect can also mean a world where a child's basic needs for care and attention are not met. This can shape the brain's reward system, the part of the brain that helps us learn about positive aspects of our environment and motivates our behaviour. Over time, the brain's reward system can learn to respond differently to things like positive social cues. Neuroscience studies have also pointed to changes in the autobiographical memory system, our memory of everyday past experiences. Following trauma, negative memories appear to become more salient, which means they become more prominent than positive ones, and everyday memories can also become less detailed. This is a problem because we need to draw on past experiences to help us deal with new social situations. Neuroscience research is showing how childhood trauma can create latent vulnerability, increasing the risk of later mental health problems like anxiety and depression. This vulnerability is not just located in the child, but arises through their relationships. Helping children who have experienced trauma still requires ordinary boundaries and consequences, but it also requires us to step back and reflect and see behaviour that we find challenging in a different light. A child may simply be doing their best to survive now, with brain adaptations from the past. We know a child's brain has the capacity to continue to adapt. For this to happen, they need our help to build and maintain trusted relationships, manage everyday stresses, and prevent new ones from happening. We need to encourage them to try again and believe things can be different. This is far from an easy task and takes time. Science is helping reframe our understanding of childhood trauma. Seeing children's behaviour in a new light can mean we respond differently. But there is much still to learn. Working together, we can develop more effective approaches that promote resilience and recovery. We can help children build trusting relationships and create opportunities for their brains to adapt in new ways.
Really great video. Okay, so developmental trauma, let's have a look at that. So we're talking adverse childhood experiences here. So emotional abuse, neglect, physical abuse, sexual abuse, illness, loss and bereavement, disasters such as war and displacement, COVID-19, surviving accidents, that's survivor's guilt, deprivation of liberty, trafficking, and even young carers. And what we do know is that it's very rare that it's just one of these. It's usually 2, 3, or even 4 of these experiences that are in play. So, okay, so let's have a look.
Did you know that what happens to me as a child has a huge impact on the rest of my life? Some children grow up in a supportive, happy environment where positive relationships can make them feel safe. Others grow up facing difficulties which can have a long-lasting negative impact, even affecting what kind of adult they'll become and what health conditions they'll have in the future. These stressful events in childhood are called adverse childhood experiences, known as ACEs. ACEs was first identified in America. After a study found as the number of stressful events as a child increased, so did the risk of experiencing a range of health conditions when you're grown up. These stressful experiences in childhood include different forms of abuse, physical and emotional neglect, and things that can happen to your family, like domestic violence, adults with alcohol or drug problems, parents splitting up, having a mum or dad with a mental illness, or having someone from the house in prison. But how does this affect me when I grow up? Well, the more ACEs I have now, the more risk I'll be affected when I'm an adult. If I have 4 or more ACEs, I'm more likely as an adult to suffer from heart disease, develop type 2 diabetes, be in prison, have committed violence, or do things that are bad for my health, like smoking, drinking, and taking drugs. There are also other things which can have similar long-lasting effects on my health, such as bullying, losing a parent, not having a home, and being poor. In Scotland, 260,000 children are living in relative poverty, and out of those, 7 out of 10 children living in poverty are in families where at least one adult is working. After you're grown up, not all work is good for your health, and being in work doesn't always mean you're not poor. A study in England found that people who have experienced 4 or more ACEs were 3 times more likely to live in the most deprived areas. So inequalities matter. Please help me and others like me. There are things you can do to help prevent ACEs. Talk about them. The more people know about ACEs, the more they can think about them in everything they do. If you work with children, have a think about whether they are experiencing an ACE and what impact it might have on them. Chances are you might have experienced an ACE, maybe more than one. What impact has it had on your life? Was there anyone you could speak to about it? Research has said that having an adult that you can trust and speak to could help stop the negative effects of ACEs. If you work with grown-ups in services such as homelessness, addiction, or prison services, think about the impact of ACEs on them and what impact it might have on their children or kids they might have in the future. If you work in a school, think about how your work can help support children experiencing ACEs and what can be done to prevent them. Are there other people outside your own work that can help us combat ACEs? Can you work with other people to help prevent them? Please help Scotland be the best place to grow up. People like me shouldn't have to suffer, so what are you going to do about it?
Okay, so the prominent features that we see here are heightened sense to sensory experience. So if you can imagine hearing a loud noise and that young person just jumps out the skin, kind of like that, crossing a road, that danger all around them, seeing somebody have an argument and the way they respond to that, because straight away they're right back in that that experience. Hearing raised voices, you know, the sensitivity to arguments and things like that. You know, the ability or kind of like that courage to communicate their needs is really kind of rock bottom, really. Low self-esteem, lack of containment, just they don't have the tools. Sometimes they have some and sometimes they don't have enough, but having the tools just to, right, this is what I need now, having that little word with themselves. And then we see social isolation, because of course what happens is these young people avoid getting involved with any groups for fear of experiencing something like this, and risk-taking and reckless behaviours. And that's when we see, well, do you know what? I don't matter. I'm worthless. So who cares what I do and if I come to any harm? So I'm just going to skip that one because it's a long, but I want to talk about disassociation. So this is one of the most prominent features following trauma, and I see it in adults and I see it in children. It's, imagine, you know, you have a patient or a client and they're sitting with you and all of a sudden they just go. It's that kind of, they're there and they're not, and their eyes become quite vacant. This is an example of disassociation. It may be that they're telling you a story and they go so fully into that narrative that they forget you're even in the room with them. It may be that they start to shake and have those physical responses to the trauma they're trying to tell you about. So yeah, it's disassociation it's quite a complex one, but it's almost like imagining you actually start becoming an observer. You're so not attuned to what's going on in your environment that you're just wrapped up in that, you know, telling your story or going back to the experience that you're talking about. It is potentially harmful, and this is why we need to make sure that those who live with that disassociation presentation, have some kind of safety plan, maybe that kind of plan that says, okay, so what happens if you are crossing a road? You know, how can we keep you safe? We know this is going to happen, and almost what do you need to come back to the room? Is there anything that we can do for you and with you, which will bring you back and kind of really anchor you back into the environment you're in? It requires really careful management by both practitioner and young person. The most extreme cases are the ones that potentially might exhibit some kind of violent behaviours, and that's something that we really need to watch. I think if there's a history of that, we need to be aware, because if a young person becomes so disassociated that they start hitting out, we need to ensure that both client, patient and practitioner are safe. So disassociation and trauma. So it feels like you're disconnected. You're not really there, like I say. You might even have that experience of standing to the side of your body or above it. Feels like you're watching something rather than being a part of it. You're watching your own life. So who we are has changed. You've become somebody else, somebody who feels really vulnerable. The world becomes foggy or abstract. Even that kind of like visual disturbance where things start to become a bit flashy and things start to move. You're uncertain about where you start and where you end. And the same with others. Memory loss. And this is why when we work with people, we often find these traumatic memories are buried somewhere, and all of a sudden, boom. And I think, you know, a prime example of when this happened was I was working in sexual trauma during COVID. So I was working with adults and young people who had experienced rape, sexual abuse, you know, across the board, really. And what we found was we were getting more and more referrals from people who had successfully, until that point, buried their trauma somewhere. And they were given that chance kind of during lockdown and everything. They may have been on furlough, nothing to do, and it started coming forward. And I think the trauma of COVID, the uncertainty of COVID, again, almost became a little bit of a hook to help get it back from the crevices in the back of their mind. So we kind of we saw really frequent recall, those memories come back. So as you can imagine, referrals just went up and up and up. And then of course there's the different identities, that there might be another part of myself that is within me, and that part of myself might be, you know, best case, a warrior, a protector, but also it might be somebody that's out to harm me, that represents someone that's harmed me previously. So with therapy, our goals are to educate and create that self-awareness. So really educating the client, you know, exploring that, you know, what it might be with them, you know, not telling them what they're feeling, exploring it alongside them, exploring what disassociation means for them and how they can manage those episodes. And again, looking at that safety plan is really important. So we need to listen, and we need to manage the environment that we're working in, you know. So if we meet with one of these people, or young people in our case, then we need to make sure the environment's safe and that the time is safe and that no one's going to disturb us. We need to kind of like explore when the disassociation happens. Could it be when they're in school, when they're in like a constraint environment, that kind of somewhere they don't feel they can get out of? It might even be at home, who knows? For some people it could be just going for a walk, because, you know, that's a trigger in itself. We don't communicate judgments, you know, or our own opinions, and we always remain person-centered. We don't speak for them, we take a step back. And we always communicate that safeguarding and confidentiality agreement as appropriate. You know, again, if I need to share anything, the first person that knows that I'm going to share it is my client. Spend time signposting, creating that next steps plan, including all of the services that might be able to support, and actually managing referrals too. And for us, you know, we're not, you know, we're not immune from trauma ourselves, and hearing somebody else's experience and life experience of trauma is really impactful, you know, and this is why, of course, our supervision's so important, and that we manage that and look after ourselves and never ever see these patients and clients back to back. We definitely need that time to decompress. Okay.
Today, we'll be learning them.
We know that. So, okay, so mantras are great. And I think this is one of the things I do with young people. So that other video was all about the 5, 4, 3, 2, 1 that you may have seen, that find 5 things in the room that are blue, 4 things that are silver, 3 things that begin with the letter L, 2 things that smell a bit funny, and 1 thing that belongs to you. It could be any of those things, but I think that's one we all know. So mantras, I often encourage that, you know, young people find a safe place and just have a word with themselves, you know. So I'm safe right now, and I am strong. And the reason I'm strong is I've got here, I've experienced all of that stuff and arrived at this point. So actually I must be strong. I know this feeling is not going to last. It's lasting now and it's horrible, but I know it's going to pass. And I know what I need to feel calm. And again, that might be just getting out of the confinement of a classroom. It might be about having something that's very mindful and sensory in their bags, or whatever that may be. Tapping. So the tapping, I'll just quickly show you some of this. So this is something that we can use to really support young people in self-regulating. Just move it on a bit. So again, you know, it's amazing because we're using 2 parts of the brain when we do this.
Is it supposed to be sound, Lucy?
Yeah, is it not working?
No.
It's only music, I have to say. So I think the tapping technique, to be honest, is a session in itself. But what we do know is that kind of, even if they work out their own circuit, and it can be the inside of their wrists, below their thumbs, above their eyebrows, collarbones are really important too, that actually they can create their own circuit for regulating, which is really useful. Just going to go to the next slide. Okay, so the circle of control is really important, and we use it all the time because it is so adaptable. So what we need to talk about with the young person is, what can you do about this situation and what is out of your control? And again, we can talk about that on a larger scale, or we can break situations down. So anything that might lead to feelings of anxiety or stress, you know, we can repeat this exercise again and again. And just to say, I worked with an adult not long ago who created a poster, and he had a man cave. It was fabulous. He had this man cave and he drew this massive circle, and it became almost like a piece of artwork, and he kept adding to it. And he kept pointing at the back when I met with him online. I've added this to it and I've added this to it. So actually you can create a really colourful poster you know, with your client or with your patient, and just keep utilizing it. Keeping that companion journal, social prescribing, and actually taking small steps, because as we know, joining a group is absolutely anxiety inducing for any of us. So just acknowledging that and saying, okay, so rather than go straight in there, what do you need? What steps do you need to get into that group? Identifying your supporters and your helpers. Celebrating who you are, not making any apologies for the fact that you're wearing lime green and orange leggings. You know, it's fine. It's part of who you are. Celebrate that. Recognize everything you can control or influence, and try and release the things that are up to someone else or totally out of your scope, really. And enlist the support you need so you feel able to take the steps out of your comfort zone and take on those new challenges, which is really exciting too. So takeaway, we know that trauma is time-based and responses can come and go. We know trauma can be acute, chronic, or complex. We know that trauma does influence childhood development physiologically and emotionally. Developmental trauma can impact negatively through our adult lives, unless, of course, you know, we do some work on that therapeutically. Disassociation requires careful management and risk assessment. We need to respond sensitively and mindfully and use the right kind of strengths-based language. A safety or grounding plan is always recommended. And there are loads of grounding exercises out there. I mean, I don't know if you've all heard of the hand breathing, where you literally take a deep breath in as you trace up the side of your thumb, hold the breath, and then exhale as you go down the inside of your thumb, and then repeat, breathing in as you go up to the index fingertip, holding it and exhaling, and literally going round the fingers, repeating on the other hand. Really is great to do again and again. Great thing is you can do it on the bus, you can do it in the classroom, just under the desk or under your bag. No one's got a clue, so nobody feels self-conscious. And you know what, again, recovery or management is possible. You know, trauma unfortunately can't be erased from our lives, but it can be acknowledged. You know, people can get through this and actually create management, and in some cases even a superpower. You know, it can become their absolute strength in life. So they're the takeaways, and that is it from me. Has anybody got any questions on that one?
Thanks, Lucy. That was fascinating. And I particularly like your explanations about the tapping and the finger breathing exercises. I think those are actually incredibly useful. And I can just imagine some of my patients who would find that incredibly beneficial at managing their symptoms. So thank you. I think that's certainly two things that I'll be looking into further to find out more information about those. So really interesting. Anne-Marie, I think you'd briefly unmuted before I stepped in. So please, any questions?
Yeah, I think I'll be able to I've got the details there to contact Lucy. I'm just starting work in a children and young people service in the next 6 weeks. It's called the Closer Project. So we're providing the psychological input for young people 16 to 21 that are just leaving, care leavers, and they've noticed that there's gaps. So the government have provided funding to us to go into the residential properties and work with them, so hopefully they don't end up, you know, into crime, into the gangs and all the other things. So yeah, we might be in contact, Lucy.
I do hope so. That sounds fascinating.
It is. It's a brilliant project. I'm so excited. I'm a DBT therapist, so I'll be using a lot of those skills to help the young people. Hopefully, it's just I haven't worked with the 16 to 18. I've always worked with adults. So yeah, it was interesting to hear about the adolescent brain.
Right, thank you.
Thanks, Anne-Marie. Any questions from anybody at all? I think Lucy's a fantastic wealth of information, so now's your opportunity. I'm just going to check if there's any questions on the chat. One moment. Michelle's asking, is there any possibility that we could share the slides, Lucy?
Absolutely.
Is that okay with you?
Absolutely. 100%.
Fantastic. What I'll do, everyone, is I'll get our admin IT team to share the slides with all of you, so at least you've got the information to hand. You've received lots of thank you messages in the chat, Lucy.
It's my pleasure.
If no one else has a question, I'm going to fire with one, if that's okay. It's related to medically unexplained symptoms, basically. Lucy, I wanted to find out, in your experience, have you ever come across any cases where, I know you've talked about delving deeper into the history and finding out when the symptoms started, trying to find out what that, I guess, trauma or an experience or something might have been during life. Have you ever come across any cases where you've delved deeper, and the patient A, either cannot think of anything, or B, is in complete denial that it's related to that and is sort of adamant that it is definitely something physical, and sort of denying any psychological involvement? Have you ever come across that? And what do you do in that situation?
Do you know, if I'm being honest, the answer is no. However, what I will say is that I've worked with young people who have a diagnosis, and that might be POTS or something like that. And then they still experience additional medically unexplained physical symptoms, and actually they've got POTS, nothing else, but they work themselves up so much that, gosh, maybe I've got a brain tumor, or that it's kind of that add-on medically unexplained.
Yeah.
That's what I've seen a lot of. But if I'm being honest, I'm not a quitter. So it's almost like I kind of will stick with them until we get there together.
Yeah.
So yeah, that's been really, really helpful. Yeah.
That's fantastic. So is it more almost the case of, actually, if you delve deeply enough, chances are there will be something. It's just about the amount of time and focus and effort you put into each case.
Yeah, absolutely.
That's
Yeah, it's
fascinating.
been a real learning experience, and I suppose now I've taken that experience into my role at BU Knots, and I'm trying to educate everybody else that actually it's so important that these young people feel that they've had that validation as to what they're experiencing, and actually they've all been fantastic and taught me so much, which is great.
Thanks, Lucy. Any final questions, everyone? And it doesn't have to be related to necessarily to medically unexplained symptoms and trauma. It could be related to the services, so BU Knots and ABL Health, if you wish as well.
And I know, just to say, if there are any other topics that you'd like me to come and talk about in the future, I'm right here. I'd love to be able to help out. So
thanks, Lucy. That's really, really, really useful. And yes, you will most probably hear from me.
Good. It's a pleasure.
Always. Wonderful. If there's no final questions, I'm impressed with our timekeeping. Thank you, Lucy, for running perfectly to time. If there's no final questions, we will leave everyone to get on with their afternoons. Thank you all for coming. Big thank you to Lucy, and we will be sharing a feedback survey with you all. So please do provide any feedback, both negative and positive, of course. We do like to learn from our sessions when we, and it doesn't have to be necessarily about me or Lucy. If you're having any issues related from the IT side of things or access or anything like that, do feedback about that as well. And if you can think of any further topics related or completely unrelated, please let us know as well.
Thank you so much, everybody. I know I've not seen you all, but I felt the warmth and the welcome, so thank you.